Well, good morning. And first of all, thank you to all of you to join in what I consider to be a very important and usually underrepresented topic of sleep medicine. First off, my name is Wajahat Khalil. I'm an assistant professor at the University of Minnesota. I'm a staff physician at the VA Medical Center here in Minneapolis. By training, I'm a pulmonologist, sleep specialist, and a critical care doc. So all that perspective, with a lot of interest in advanced underlying lung disorders, cardiopulmonary physiology, and respiratory disorders associated with sleep, and an interest in chronobiology. So with that said, I'm going to take my video out so you can focus on what is more important. The topic for the day is chronobiology from a perspective of human sleep and circadian sleep disorders. Even that narrow approach towards this topic is still very broad. So the goal of my presentation today would be to make you fly, say about at 30,000 feet first, and then dip down, lower to pick up some of the salient and important features which are important not only for your training, but from the perspective of your board examination. Feel free at the end of the presentation and later, even if you want to reach out with any questions in this regard. I have no disclosures, and I will not be discussing any off-label use or investigational use during my presentation. The learning objectives for the day is first to define circadian rhythm, explain the differences between biological rhythms, describe sleep as a function of circadian rhythm, identify various tools to measure circadian rhythm, and describe various circadian disorders. And finally, take a shot at explaining some of the tools which can be applied on phase shift and treating various circadian disorders. Now, us as life on this planet means that we need to be very familiar with how life has evolved over millions of years. 4.5 billion years of stated life of our Earth as a planet, and then life emergence probably in the order of around 1 billion years later. As we know that the evolution started somewhere in the deeper crevasses of the ocean, and the life didn't see light probably till around when it started reaching the 200 to 300 meter mark of the ocean water. But as soon as it reached that area, it had to deal with two important things: the significant variation in a 24-hour cycle to light and no light, and what it accompanies and compounds with temperature and variation, and also the tilt of the planet, which basically determines the distance from our star and the availability of heat and light on that regard. So what I'm trying to push into you guys is that the biology, when it faced that, started learning something about this particular process. And it then started incorporating in probably through an evolutionary process over millions of years. So whatever is the outcome of that is not something which is brand new. And if it is not brand new, it means that it is associated with the very core of our existence on this planet. Chronobiology is a science or study of the effect of time, especially rhythms, on living systems. And basically, it is the intrinsic adaptation of that life. The circadian rhythm, or circadian, coming out of the Latin, stands for a biological process which displays an endogenous, and I mark it again, endogenous frequency of oscillation of around 24 hours. If this is less than 24 hours, that rhythm will be called ultradian. And if it is beyond 24 hours and up to about a year, it is called an infradian rhythm. While I'm describing this, you guys are already jotting down in your mind about various biological rhythms you're well familiar with. For example, our hormonal system in a 24-hour day, some of it responds to a 24-hour frequency fluctuation, while the others have a frequency at a much higher level than that. So there's fluctuation during the daytime and the nighttime, it falls into the ultradian rhythm. The infradian, the menstrual cycle in humans is an example, and certain activities of hormones in our body. And then finally, the circumannual is basically determining beyond a year timeline of biological rhythm, animal and bird migration as we're familiar with. The two main rhythms which we will be focusing on will be the circadian and the ultradian rhythm. And I'll explain the ultradian portion later, because I think the common knowledge is the association of sleep behavior with circadian, but there is more to it, and there may be a role of an ultradian rhythm involved. So let's talk about what sleep is first. It's a cyclical behavior, which is marked by characteristic immobile posture and diminished but readily reversible sensitivity to external stimuli. Now, some of you might scratch your head as it's pretty broad here. And I would argue that it is better to be left broad than to narrow down and then you can't fit the whole realm of sleep in it. So the most important thing here to note is the cyclical pattern. And now, since it's cyclical, you need to figure out its oscillation and its time. And what we have figured out, based on its oscillation and through common experience, that the fluctuation is within a 24-hour cycle. So it is circadian in rhythm nature. Sleep itself is a byproduct, is a byprocess product, which involves process S, as we all know, the sleep homeostasis, and process C. And it's the culmination of these two products which produce what we call the alerting signal. Now, process S is sleep homeostasis. It's like a potential energy where it will keep on piling up on you the more you're lacking sleep. So, and it will start going down immediately once you start going into sleep. It has a steady rise over time and then starts declining during your sleep time. While the process C seems to have a bit of a dip earlier in the day, and it gradually rises and peaks at around 9 p.m. And then it goes down during the sleep phase of the normal population till it starts rising up again the next day. When you overlap these two processes, you actually get what we call a sinusoidal wave with a dip during the daytime, or at least that is the dip which we have picked up earlier on. There are dips in the night as well, and we'll talk about that later. But this particular dip is present usually between the order of around 11 and 3 o'clock, or the siesta time. And basically what this means is that your process S, or sleep homeostasis, is gradually building up, while the process C, or the circadian process, hasn't caught up to that mark yet. And then there is an overshooting of the process C later in the evening at around 8 to 9 o'clock. And this is what we call the second wind phenomena, that you get more alertness around that. And after that, the circadian process starts going down. So our understanding of circadian rhythm in biology is nothing new. The first time it got described was back in the early 18th century on the mimosa plant, where the French scientists noticed that independent of whether the light exposure was there or not, the mimosa plant closes and opens itself in a 24-hour cycle pattern. So that was the first documented and stated fact of circadian rhythm in biology. But it wasn't till later in 1938 that for the first time, Natalia Kleitman at the University of Chicago took this very interesting experiment into the deep caves, Mammoth Caves in Kentucky, and forced the subject to what we call complete isolation from the environment. And this was replicated again back in 1962 by Ashraf and Weaver in Germany. And what they did was they used the Second World War era, deep underground bunkers to conduct this experiment. So what you see on your right here is actually the replication of the experiment done by Ashraf and Weaver. In the top portion, you see the natural conditions. So the subject is in a bunker deep underground, but is able to communicate with the environment. The door is open, and they're able to maintain a relatively stable sleep-wake cycle. And the triangle in between on the solid line is depicting the core body temperature nadir, or the lowest core body temperature nadir. On day 10, the isolation was started by closing the door, and no environmental contact was made. And what they noted was that there was a gradual progression of the sleep-wake cycle later into the day, all the way up to day 35, when the doors were reopened. And there was a time, and they stopped the experiment at the time when the entrainment was complete and stability of sleep-wake was achieved again. And through that experiment, what they found was there is an intrinsic clock when we as humans are isolated from the environment. And what they measured back then was in the order of around 25.4 hours, so longer than the 24-hour cycle of our planet. Later experiments, and now actually measuring the exact the signal of our genetic clock, we know that this number is around 24.2 hours. Again, the 0.2, and there's something to be said about why there is a need of why the slightly longer cycle than the rotation of the Earth of 24 hours. And and we can speculate and suggest that this could be an adaptation to the tilt of the planet. So we can adapt beyond, and as farther away we go from the equator, is that an evolutionary adaptation mechanism for that tilt? Some people took that thought seriously and did conducted experiments in various races. And what they did notice, they couldn't go to all the regions, and these experiments are very difficult, we need to understand. But our ethnic backgrounds and our race does depict the longest of the evolutionary things which we have accumulated over time, and it remains relatively stable. So it's a good place to start. So when they compared, they found that the African Americans population here they had a slightly shorter intrinsic clock time than 24.2. So we all need to, for what is the practical use of it? Well, we need to understand that this particular intrinsic clock time varies between people to people, region to region maybe, and more experiments needs to be done to confirm its association and relationship. But for the immediate purposes, whenever we are trying to deal with circadian disorders and conditions like traveling and jet flight, we need to keep that in the back of our mind. Now, here comes the part where I'm going to slip this up front so you guys can recognize that what you're obviously seeing is the dip and the peak of a circadian biological rhythm on the overlying these multiple dips which you're seeing, the peaks and troughs. But what we do know is that even during our circadian high, we have dips, and there are more than one dip. And those are in the circadian high, we have certain troughs of low. While in sleep, as you all recognize, that our sleep cycles, and there is, there is a thought that could sleep cycling be associated with this intrinsic ultradian rhythm, which kind of takes the overlay of a circadian pattern of sleep behavior and then triggers shifts in stages of sleep. So for example, in a circadian low, an ultradian high, can that result in, and is the explanation for REM behavior, for a REM sleep, versus the frequent arousals, when the natural arousals which we have in our sleep, are they on the ultradian high while we're in the circadian low? These are all important questions, which are, which requires ongoing studies to confirm, but it's an interesting thought. All right, so based on this, what we have established so far is that we, as humans, have an intrinsic process which maintains a clock which is relatively in close relationship with the environmental time cycling which is happening on the planet. So the obvious second question is, where is that? If that is a timekeeper, where is that timekeeper? So the major, or the master clock, or the timekeeper, is located smack right straight behind our eyes in the sella turcica, and the suprachiasmatic nucleus. It's like a generator, if you want to think about it that way. It takes certain signals which promotes its signal, its activity, and there is a feedback mechanism which decreases its activity. And the feedback loop is part and parcel of this whole cycle, which I will explain. So through the retina, the light exposure, and by the way, the light exposure, not every light is the same light. So the spectrum of the light does determine the effect on your circadian rhythm and phase. And for practical purposes, the shorter frequency lights have the most impact. Visible light, I must say, that has the most impact on our circadian rhythm with phase shift. So, and that would be your blue range, as we are, more and more experiments are coming and confirming that as well. So retinohypothalamic tract is the straightest path behind the retina all the way to the sella turcica, and then through an indirect path of the IGL. And presence of light, or exposure to a photon, is the strongest signal for this, the suprachiasmatic nucleus as a positive reinforcer. There are other signals coming from the raphe nuclei, and there's the negative feedback loop, which goes through the preganglionic nuclei, the superior cervical ganglia, postganglionic nuclei, into the pineal gland. And we all know what is secreted from there is melatonin, has a paracrine connection back on the SCN, and it slows it down. Bottom line of all this activity is, number one, the circadian sleep-wake cycle, which we are well familiar with. But downstream, a lot of other processes are also associated, and it's important for us to recognize that they're all interlinked. Neurobehavioral, overall performance, so physiology and biochemistry, is closely interlinked with how, with the circadian, or mood, cortisol, as we all know, melatonin, as we all know, core body temperature, and your heart rate are few to just mention here. Now, the field of circadian biology was, and chronobiology was brought onto the limelight in 2017 with the award of the Nobel Prize of Physiology and Medicine to these three great gentlemen. Jeffrey Hall, Michael Robash, together and Young independently, worked on a similar project and produced similar results. And what they did, I will walk you through the history of it. So in 71, Benzer and Nopka first, and it was an accidental discovery that they discover a mutant of Drosophila, the fruit fly. And what they noticed was that this mutant displayed alteration in the normal 24-hour cycle of the pupil occlusion. Well, what is interesting to know here is that Drosophila does display the intrinsic circadian clock, which is very similar to us. So how useful. And this fly has served so much in our human science and continues to serve us even more. So once they discovered that there was a mutant, they immediately asked the question, can we work on it and figure out and narrow down the gene if there is a genetic component to it? Back in 1984, for the first time, Hall, Rabash, and Young separately, independently, discovered the period gene. And they identified it and then they characterized it. In 94, Hall and colleague, Hall and Rabash went further and discovered timeless, the second gene, which was involved, that allows basically the period protein to come back into the nucleus and stop the process of transcription of the period gene. Finally, in the 1994s up till late 1990s, so 97, Takahashi and colleagues started putting all these things together and started coming up with what we call a unified explanation of what is considered as the cellular clock. And that's very important. That this paradigm shift of our understanding of how we, life, and particularly humans, are interacting with the environment, and how do we keep and tally our time. So I know I put quite a few lines and dates here, but let's get to the action of understanding what they actually did. So if you can see what I'm depicting here, the outline is for the cell. The green area right here is the cytoplasm. The blue line is circling up to the nucleus, okay? So you've got your DNA. First thing first, the BMAL1 and clock genes gets transcribed, and they find a dimer, they make a dimer, which then acts as a, attaches to the promoter region and acts as a pro-transcription or enhances transcription of per and cry, so period gene and cryptochrome gene. This in the nucleus then goes through the nucleus into the cytoplasm, into the ribosomal area, and gets translated into period and cryptochrome proteins, so capital, uppercase per and cry. Uninhibited, these will find that these two will combine and make these dimers right here, which will then go back into the nucleus and inhibit the BMAL clock transcription zone. So if you can see, this is a circular path. And what is interesting to know is that this is the circular path which comprises our intrinsic clock. So literally the 24.2, which we're talking about, is the transcription, translation, post-translation inhibition, and transcription factor inhibitor by the protein diameter re-entering dimer re-entering the nuclei. So that's an interesting thing. Now, how does this progress is that there is another interesting protein called the casein kinase, which which can phosphorylate both per and cry. And the moment it phosphorylates, the period protein gets destroyed. So it cleans up the cytoplasm. So on one hand, it decreases the concentration of per and cry protein translation, and hence the dimer formation is going to get less and less over time. And the second thing is it actually goes back into the nucleus and destroys the per cry dimer, which was inhibiting the BMAL1 clock cycle. So if I may go over this thing again, per cry gene transcription goes into the cytoplasm, translated as per cry protein forming dimer, going back into the nucleus to stop the BMAL cycle, clock transcription cycle. While this casein kinase inhibits or destroys these proteins decreasing its concentration, so dimer formation is decreased. Also, whatever is present of this complex of per and cry in the nucleus is destroyed as well. And this whole cycle is what determines our intrinsic clock. And I will explain, what that is called later. Now, what is interesting here is that the casein kinase mutation leads to rapid accumulation of period back into the nucleus, and the period cry blockage of the BMAL1 and clock. And it's actually the reason, the first identified reason for what we call familial advanced phase sleep disorder. So there's a direct genetic implication of this process. Now, what comes out of this is a biological rhythm, okay? And a biological rhythm is represented in a form of what we call a sine wave. It has a peak and a trough. It has a midline, and it is important for us to recognize what those salient features are called. And there is a reason. So then you can apply this in calculating and projecting certain features and measurements of circadian rhythm. So a cosine curve basically has a peak, a trough, and a midline. The midline is called the mesor. The amplitude is the distance, the peak distance between the mesor, the midpoint, all the way up to the peak point. Can be taken it for the trough as well. So the distance from the lowest point of the nadir or the highest point in the peak from the mesor is your amplitude. The acrophase starts from the lowest point of the trough all the way up to the peak, the tip of the peak, and that is the acrophase. Now, if you can see, what you're trying to do here is you're creating some geometry and some measuring tools. So if you know one or few, then you can extrapolate about other data. So this is how circadian rhythms are measured, rather than following it dot by dot, second by second. So if you have a certain amount of data available, for example, what you do in an actigraph, when you give your patient an actigraph, it is calculating, it is measuring movement. And if you have a certain, persistence of a rhythm time and time again, then you can calculate and extrapolate certain other features of this waveform and predict. So it's a good tool to understand and use, and it is used frequently in the measurements of circadian rhythm. So what are the various markers of circadian phase? First of all, I want to tell you that these are just the few which we use or we are using, but a lot of our physiological functions have a circadian link to it. I mean, needless to say that our heart rhythm, our core body temperature, certain hormonal activities, they will all depict this particular sinusoidal waveform, which I just described. But let's get familiar with some of the ones which we do use in measuring circadian rhythm. So you need to understand the CBT minimum, which is the core body temperature minimum and point. So this happens during your sleep, and we will talk about when. DLMO stands for the dim light melatonin onset, and it usually occurs, it's the onset where the melatonin crosses the mesor and starts going upwards. It usually happens 2 to 3 hours before your typical sleep onset. And you can actually calculate about the core body temperature minimum by adding 7 hours to your DLMO time, and vice versa. You can, if you know your DLMO, you can do the CBT calculation, and if you have an idea, if you're following the 24-hour core body temperature and you know your core body temperature minimum, you can calculate your DLMO in that way through this formula. Few other things to understand. So remember what I talked about that whole cycle, the clock cycle, going from the BMAL clock transcription, then per cry transcription translation loop. That whole cycle is what is called the intrinsic or the endogenous pacemaker rhythm, or tau. Any periodic stimuli which can have an impact on this tau and can change its rhythm is a Zeitgeber, or a time giver, German. Things like the strongest one of that is light, but temperature, pharmacological agents, exercise, your habits, eating and drinking. So many things are giving these signals back to us and can influence or affect our intrinsic tau. Well, the intrinsic tau is solid. That's your genetic signal. But how it is going to interact with the environment is what is going to be impacted by its interaction with the Zeitgeber. And what is the result of that is what is called psi, or the phase angle relationship, which is the relationship between your intrinsic circadian rhythm and its interaction with the time givers. So the equation is written as, you can see, psi is equal to tau minus Zeitgeber. Now, in an ideal circadian lab, where you can control almost all, I'm going to say again, almost all, not all, but almost all of your time givers or Zeitgebers, and you take this number to 0, the psi, which is the phase angle, will be proportional to tau. So you can actually figure out your intrinsic or assess your intrinsic tau or intrinsic rhythm if you know the phase angle. So that's an important thing to see. Now, if you look over here, what you're seeing is that this is in a situation where the individual is entrained. So there is constant light dark interaction, and a stable sleep is maintained. When temporal isolation, which is basically locking as many of the Zeitgebers out, starts, a free running phenomena starts. And the free running is happening because 24.2. So it's longer than your 24 cycles. So there is gradual progression of free running of your intrinsic rhythm into the 24-hour cycle day. And so this happens. And this slant angle is what is represented by a psi. So if you know what that angle is, you can predict many things, including the proportion or the relative tau that way. And that's the way most of circadian labs operate. Moving on to understanding some of these tools and how do we use them. So tau, as I said, are the intrinsic circadian rhythm. The ideal lab protocol is to create temporal isolation and force desynchrony and let that tau run a free run. And that angle which you're going to calculate will give you the measurement of what you're interested in. You and I don't deal with or live in a world where we have access, or patient has access to a perfect circadian lab. So the less than perfect alternative would be to maintain rather, constant state in our patients, keep a very close history on what their wake and sleep cycles are, document as much of that as possible objectively with an actigraph or a sleep diary as much as you can, and then measure 3 consecutive weeks DLMO. So quite a tough job. The psi chronotype, which is the phenotype of this slant angle, can be measured by seeing a regular sleep-wake pattern and picking up on what we call the sleep midpoint. And then looking at, from that point, you can talk about in the 24-hour cycle, if you plant this as an anchor, you can say, what is the chronotype of these people, morning people or morning larks or night owls. There are other tools which can be used, morning evening questionnaire, and I will give you an example of it so you know what exactly it looks like. And then logs and actimetry, which are less than perfect tools. The true psi, it requires that you have a constant routine, and then you measure circadian core, rhythms, which is core body temperature, melatonin, cortisol, heart. You have to plant them as a wave, and then use your calculations based on calculating your amplitude, your acrophase, knowing your mesor. So then you can project and predict the true psi. Amplitude, again, the same thing. Either you take an intrinsic rhythm coming out of you, plant every point of it, or as many of it, so you have the closest to the fit, cosine wave, and then start calculating those values, or you can use an actimetry. Now remember, in the real world out there, your patient works, has a weekend, and the exposure to light and all that kind of stuff is not in your control. So whatever is going to be coming out on a test, it has to be taken in in the context of whatever is out there to pollute that signal. So if you prescribe, if you give an actigraph to your patient for one reason or the other, don't expect that you're getting a gold standard result out of it. Know what are the limitations of that particular test. The activity rest is, of course, the actimetry is much more objective than maintaining a sleep log. And then how do you figure out about, or measure sleep homeostat, or, an idea of what we call the process S. And we can use the EEG and the PSG. So the delta power in a sleep, it determines, the potential energy or the presence of process S. The other thing which we can see is the slow wave activity, or the theta alpha ratio. It starts increasing in a person who's sleep deprived when they're awake. Now, for practical purposes, we have to start moving towards tools which are readily usable. And in that case, we need to start understanding the basic concepts of generally putting your population in one group or the other. So like any other, the population, the general population is distributed as in a Gaussian curve. And if you can see right here, the light blue onwards is the early type, and the green towards the right are the late types. Chronotype, which is the phenotype expression of the tau, intrinsic tau, is a combination of gene, which is representation of the tau, age, as we all know, that the sleep habits and duration changes, and the nature and quality of sleep changes with progression of age, and then the exposure of light, or in general, any Zeitgebers. This is a Munich chronotype questionnaire, so MCTQ. You probably will encounter this in research environments, but it is something which can be used in your practice as well. Basically, it starts with a question. And I'm so sorry that this is very crowded for you guys, but I think I try to, magnify as much as I can. And if you can get a copy of this, you can go over and you can download this form anyway. So basically, it has questions like, okay, what is your usual, sleep time? What time you want to sleep versus what time you are sleeping? Are you waking up with an alarm or without an alarm during your work days versus weekends? And then, it further adds up to your history in general, about as a child, as a teenager. So it's adding up all those points. And then furthermore, it adds up about the chronotypicity or the morningness or eveningness of your parents and your siblings as well. And when you compute all this together, you get a score. The higher the score, the more morning lark you are. And the lower the score, the night owl you are. So that's how it works. Okay, so I'm going to switch gears here. So up till now, what I was trying to do was to kind of make you familiarize with certain tools of circadian rhythm, understand the basic concept behind it, understand that it is a much more complex situation than, with so many other interactions of the individual in the environment. So the tools you're going to be using in assessing or measuring should be taken in the context of whatever is out there polluting that signal. So switching gears now to circadian rhythm sleep disorders. So up front, I can tell you, so you can broadly divide these into intrinsic and extrinsic types and the others. The intrinsic ones are, you're familiar with, are the advanced sleep phase, the delayed sleep phase, the free running, and irregular sleep-wake response. The extrinsic ones are your shift workers and jet lag. And the other ones, which basically can have intrinsic effect and compounding effect in general, for example, a medical condition or a debilitating, neuromuscular situation, those things can limit one thing, which can limit your activity, which can limit your exposure. So those are compounding factors, right? So some of those things have to be taught in that context. And few of the things can have a more direct effect. Certain drugs or medical conditions can. Underlying neurodegenerative condition is an example of medical conditions which can impact and can give rise to sometimes intrinsic circadian rhythm disorder, the irregular sleep-wake syndrome. The practice parameters for the clinical evaluation and treatment of circadian rhythm sleep disorders. So now knowing how they're classified, now you need to know how you test them, what are the practice parameters around that, and how do you, or what are the treatment options. So I'm going to go over gradually over it. It's a bit of a crowded slide, so it will require some of your attention right there. So the evaluation tool. So first of all, your disorders: shift workers, jet lag, advanced sleep phase, delayed sleep phase, free running, irregular sleep wake. Okay, so what is indicated for diagnostics and what is not? And as you can see, I just highlighted all in green right here. So that should capture your attention first. So you don't need a PSG for any of it, okay? The circadian markers, just because of the availability and the difficulty of conducting those tests, makes them very difficult for us to use in our day-to-day practice. So the things which are usually used are the actigraphy, right? For diagnostic purposes, for advanced sleep phase and delayed sleep phase, they're guideline. And for response, pretty much across the board, the actigraphy has been used. And the other thing which is an important tool and has been used is the sleep log. As sleep fellows and practitioners, you are very well aware of the limitations of these tools, but this is the best we have right now till we actually have a much more direct way of measuring the tau, or the intrinsic circadian rhythm. So for the treatment, what is indicated, and I'll go over those one by one. So in shift work disorder, taking planned naps prior to the work is a standard a practice recommendation. Also recommended in that is time light exposure, usually during the earlier portion of the shift work at night. Well, of course, you have to know your patient's shift time and then graph it out between their sleep-wake cycle, and then time your light exposure accordingly. But in a standard night shift, usually it's in the earlier part of the night, and you gradually start dimming down the light for them. Melatonin is indicated as a guideline. You can also use hypnotics, and stimulants can be used, modafinil, as well as you can use caffeine. For jet lag, the most important thing to note is basically time light exposure. Well, first of all, which direction the person is traveling, so east versus west. So the severity of the jet lag change, is different for East versus West, and I'm going to walk you through that. And use of timed melatonin, as well as use of hypnotics. These are the three things which are usually in your toolbox when you're dealing with jet lag situation. For advanced or delayed sleep phase, it's pretty standard indicated option for using timed light exposure. And I will tell you how to utilize them and what is the concept behind it between light exposure and melatonin. For the free runners right here, whether they're sighted or not, that's an important thing, because even if they're not sighted, they can still perceive light, and so some of them are completely unsighted, and that's a different situation. What I have been doing is I used melatonin as an anchor. So I basically, in this free running situation for them, I put an anchor where I want their sleep cycles to start. And based on when when I'm going to give the melatonin, I will use the dose. So lower dose for shift anchoring, and a higher dose for shift influence, as well as hypnosis, right? I mean, for sleep purposes. Irregular sleep wake, basically the most important thing in them is structuring their environment, because a lot of their problems are staying in the nursing home, debilitated, and so structuring the environment helps a lot. And then also you can use melatonin for time anchoring as well. So for jet lag, I think you probably already know, but I'll go over it again. The direction of the travel matters. The zones, usually 2+ is what is needed, and the more the zones, the worse the jet lag is going to be, and of course the individual susceptibility. So traveling east is worse than traveling west, and when you travel east, there is phase advancement, while phase delay when you're traveling west. And in case when you're doing 6 to 8+ hours of traveling east, your phase advancement is going to happen. So the first thing you need to do is control the light exposure. And it starts all the way. So there are various approaches which have been taken. Some would make the argument that we should start aligning or realigning their circadian clock even 48 hours earlier before than the travel starts. So it basically makes it easier for them to adapt once they land, particularly traveling east. Some would say, and some would practice by using dark glasses earlier in the day, avoiding sunlight when they land, and then gradually start exposing to sunlight later into the day, and using melatonin as an anchor for sleep. And when you're using melatonin, you're not using it as a circadian shift changer, which is the low dose melatonin, but you're using a high dose melatonin there, basically as a sleep anchor there. Coming to the phase shift and the concept behind it. So the first thing as a pearl I want you guys to remember, and you probably already know by now, is light pushes, melatonin pulls. Okay, so wherever you're going to put the melatonin, sleep is going to get pulled towards it. And wherever you're going to expose the light, the sleep is going to go away from it. And this is important to know that not every light is the same. So in the spectrum of visible light, the shorter frequency lights have the most impact on circadian rhythm. So the orange and the yellows are not that important as the blue. So you need to know that. The core point to remember is identification of the core body temperature. Remember the formulas which we talked about earlier? This is why you need to calculate or project where someone's core body temperature nadir is going to be, because it's important where are you going to expose the light. If you expose the light beyond after the core body negative, and you will basically cause phase advancement. It is a dose-based situation. So, and as well as there is some argument about proximity to the core body temperature. So how much of light dose you're going to use and how close you're going to be to it. In common practice, we usually try to do this once they're awake during the daytime, and we know that their core body temperature is lying to the left of it. So you want to phase advance them for delayed sleep phase. In advanced sleep phase, timed light exposure in the evening is what is going to help you to phase delay their sleep. And you know their CBT is going to be DLMO plus 7 hours into their sleep, right? So light exposure when they're awake in the later part of the evening, it's rather simpler that way. For melatonin, again, as I said, melatonin pulse. So this is a study by Sharkey back in 2002. And what is interesting to note in this particular study is that it's a dose response thing as well. So the higher dose of melatonin you're going to use, the larger phase shift you're going to achieve with melatonin. Usually when we want to impact phase shift, we usually talk about, we try to use doses in the order of around 0.3 to 0.5 milligrams. We're not talking about 3, 6, 10, 12 milligrams of melatonin. That's for phase shifting. And usually if you want to anchor that, usually you anchor at the time or around the time of the dim light melatonin onset. That's where you want to anchor it. And that way it will phase, it will pull the sleep towards it. Remember, melatonin pulls, light pushes. All right, so with that said, I'm going to use my last slide to open up your mind in a different way. Remember the slide I showed you about, the bigger picture of sleep being a cyclical behavior and fluctuating around 24 hours. But you and I, who have studied and looked at sleep studies, and look at the EEGs and look at the different stages of sleep, know that there is something happening within sleep as well. And as I was talking about the underlying ultradian rhythm. So what it opens up is a whole new chapter of understanding and subspecializing within the realm of sleep of how to create sleep and how to impact sleep. What we call sleep engineering. And can we use sleep, which is a signal of circadian biology, can we use that tool to manipulate other circadian signals, even in the realm of therapeutics? And once you start going into that realm, for example, performance enhancement is something which is very popular nowadays. But think about it this way, that how many of us have been, in medicine in general, we've been treating high blood pressure for decades. And the pressure which you are monitoring and following through is the pressure which you see of your patient when they arrive in your clinic during the daytime in a stressful situation. How about redefining hypertension as elevation of the nadir of the blood pressure during a circadian timing? So if you take that as your anchor point, it gives you a single point which you need to be monitoring and managing, and much more focused approach towards it. We all know that the relationship of hypertension, chronic hypertension, and untreated sleep disorder breathing with arousals and sympathetic tone and all that kind of stuff is basically about not reaching the blood pressure nadir during your sleep. So what I'm trying to propose here is that we need to start thinking in the field of sleep medicine, chronobiology and circadian rhythm in a different realm, just way beyond sleep wake, and maybe use or understand sleep as a tool through which we can manipulate and manage chronobiology and circadian rhythms in humans. So with that, I would stop and open up for questions. But before that, Sally will go through a few questions of her own. So now we open up to general questions. I already see a question up there, and you can keep on typing, and we'll try to address as many of it as possible. So Neha, you're asking about, do you have any experience with time shifter apps? I personally, myself don't, but I'm aware of its use. Don't have a strong opinion one way or the other. If anybody else wants to jump onto it. All right, good question. So, Kishan, right? So sleep inertia is primarily a process S thing, you know. So it's, remember the potential energy component of that, but it's a bit more complex than that, because what you're seeing basically is so let me turn back. Depending on if you're talking about sleep inertia, which I'm realizing you're talking about, is when you wake up and you are having difficulty getting to yourself, right? Your active self. That is a process C, right? Because your circadian rhythm is still on the lower side and hasn't started peaking up again. So lingering on this low alertness level is a process C thing. Your process S started dipping down and should be at the lowest at the time when you're waking up in the morning, if it makes sense. So regarding the single or double dose, delayed sleep phase, if you're talking about, okay. I mean, remember, I showed you a graph, you know, so melatonin follows the same chronobiology, you know, the cosine wave. So you don't have a single time, you have different levels. So even when you use the 0.5 milligrams, by the way, that's a huge dose for what is actually being secreted in your system, right? We're talking about picogram dose, which is being secreted in the system. Now, even the 0.5 is an overwhelming dose. So whether you want to enhance, so one explanation I can give you is that you can use a lower dose for you know, for anchoring, for phase advancement, or for phase shift. In delayed sleep phase, you basically are trying to pull up towards it, and the higher dose you can use at the time of sleep to basically synchronize sleep with presence of higher level of melatonin. So can it improve the quality of sleep is the question. I mean, there's no objective data to suggest one way or the other. Most of that stuff is all experiential and anecdotal. But from a mechanistic point of view, if you're following a curve and you are increasing the dose of that in that fashion, it makes sense.
May I add to my question? So I have actually seen where they use one single dose around the DLMO, and then there's another way of two doses where one is used around the DLMO and one is right before bedtime. So I guess the use would be more like a circadian entrainment as well as a hypnotic. Right. Is that something that you've seen as well, or is that just based on like the site where you practice that?
Yeah, no, I would say, I mean, you know, I've seen that. And there are times every now and then where where I want to achieve sleep in my, in my patient as well. So you have to use it as well. So if I'm using a hypnotic agent, I might as well use the higher dose of melatonin. So I've done that infrequently, but I've done that too. But that's not, for me, it's not a standard part of my practice. When I'm using it as a phase shifting agent, I'm using it at the DLMO point. Basically, your body needs the signal when the melatonin is going to cross the mesor, right? So it needs to have that anchor signal. If that is the purpose of it, I think the 0.5 at 6 o'clock, 5 o'clock, whichever time you want to be setting it up, remember the 2 to 3 hour timeline, will do that trick. The second dose, as you quite rightly said, is basically not about circadian shifting. It will have an influence, by the way, as I already told you, melatonin dose does influence. So it has a phase shift influence too. Even a higher dose will cause more shift. But most of us are using it, or when we're using it for hypnotic reasons, right? So I don't have a strong, I mean, I wouldn't disagree with that. But I would say that from a proof of concept point of view, I think what you wanted to show is that the melatonin has crossed the mesor and is now trying to peak.
Thank you.
So there are quite a few out there. The issue is that there are limited labs which runs for saliva-based melatonin measurements, urine-based, and so it's basically limited by where you're practicing, where what you can utilize within the reasonable vicinity of your geography, and so those are rate limiting factors. And somehow, but they're becoming more and more popular. Let me tell you this thing, that that you basically can actually now calculate and measure the intrinsic tau of a single cell in a petri dish. Okay, so you can do that. Or genetically mark it. So you can actually have a very accurate measurement of tau, but it is not available that frequent. It's being used in the research realm, where I see this, that the more and more interest in circadian biology will start beyond even sleep medicine. As I told you, circadian biology is an interesting topic for medicine in general. I mean, think about it. When we were trained, and when we started becoming sleep physicians, right? There's a whole lot of stuff which we started realizing at that point, which is physiology and biochemistry, and which we didn't tackle during our medical training as well, earlier on. So I think we're moving in the right direction of recognizing the core component of chronobiology and the use of circadian markers and circadian tools. And I think where this is heading, it will dictate that we start using this more frequently. Sure, Divya. So the thing is that, as I was, and it's a great point, what I wanted to say was that time and time again, we talk about circadian and narrow it down completely to sleep-specific, disorder-specific situation. And in my opinion, sometimes it limits our grasp of the bigger project, the purpose of understanding chronobiology and circadian. But you can only pick one or the other, at a global level, because it's an extensive topic. So we can, I can redesign a conversation or talk around clinical, clinical cases and clinical vignettes, and then we can talk about practical applications in that way. But to understand chronobiology, it takes so much time of going into that presentation that I think what I would propose, Sally, if you're up for it, is to have more of what we call a case-based learning experience where circadian disorders are discussed in that fashion too.
Actually, we do have a planned presentation for the May webinar. Young learners are able to submit unusual cases and present them during the May webinar. So hopefully we will be able to get some great topics to discuss in May.
Yeah, I know that. There you go. So, and again, I mean, I just wanted to reiterate that one of my wish as an educator in sleep medicine is to expand and open up this tremendous field of chronobiology and incorporate in the broadest way possible for sleep medicine, right? Because we might become the, cancer biology is using chronobiology, circadian biology. More and more people are getting into therapeutics of it. We who are essentially sitting and understanding and dealing with the most important signal of this circadian biology, which is sleep, right? Sleep-wake, are probably well placed to adapt and benefit and then develop this field future. So one of the thing which I really wanted to do was to open up, hopefully, and expand you guys to start thinking in that direction.